Going to start, okay?
Okay, sir. It's live now, sir.
So we can start.
Yeah, you can start.
Okay, Awal, we can start. Please go ahead.
Okay. Good morning, everyone. So the topic for today's talk, choosing an empirical antibiotic in sepsis. I think one of the most useful and most difficult thing to decide. Antibiotics are certainly one of the few truly disease-modifying therapies available and by far the most commonly used in our ICUs. Everybody will agree on it. And if you think IV antibiotics need some magical thinking, well, I am somehow doubtful about it because the choice of antibiotics will directly influence the patient's survival beyond timing and the dose. And it is not some magical thinking what we should talk about. It is all about the scientific basis on which we decide about the antibiotics. And this is what we'll be discussing in the next hour or so. So the impact of adequate empirical antibiotics has been shown to have an impact on the clinical outcomes, the mortality rate. And beyond that, not only the clinical outcomes are affected, the microbial resistance and the costs do come down when we talk about the judicious antibiotic selection. So this first intensive care case mix from Indian ICUs, the INDICAPS 1, it clearly showed that although around 1/3 of the patients had severe sepsis or septic shock in the study, but more than 2/3 of the patients received infection without, received antibiotics without any infection at all. So this is where we need to think and ponder about that where and how we are prescribing our antibiotics. The subsequent INDICAPS 2 again showed that the ICU mortality was pretty high in sepsis subset, up to 35%. And the predominance of gram-negative bacteria was there. Around 3/4 of the patients had gram-negative septicemia, and only 13.6% had gram-positive bacteria, and fungal were only around 10%, which is unlike the Western data. So we need to look into our Indian data. And what was more alarming was that around 16% of the patients were receiving more than 3 antimicrobials. So this is again a thing we should look into. So this newspaper clipping published around 4 years back created a lots of hue and cry in the lay public. This was published in this was an ICMR report published in Times of India, which said that drug resistance is a growing problem. But what was more important was that this particular thing, which said that antimicrobial resistance has been increasing, mainly due to misuse or overuse of antimicrobials, including antibiotics, not only amongst the humans, but also amongst the animals. So even WHO has said that if antimicrobial resistance is not tackled right now, by 2050, one person could die every 3 seconds. So if I talk about my antimicrobial use, certainly we all know that antimicrobials are amongst the top ICU spends, mainly because sepsis is the topmost player in our critical care population. Sorry. Can you all visualize my slides? No, I think. Dr.
Yes,
Hunt.
we can see my experience with antibiotics on
Okay.
the uske baad, it's all blank.
Okay. Sorry, somehow there is a problem.
Okay.
Can I just reshare, please? Just a minute.
Yes. Yeah, please.
unable to move it. Let me just. Yes. Okay. So antibiotic use in the ICU, when we talk about it, there are multiple places where we can put in the antibiotics. Firstly is the anticipated infection. When we talk about that there can be an infection and we try to give prophylactic antibiotics, like when we are talking about the preoperative patients. Then other clinically suspected infection, that is where when we are suspecting some infection and we give to the empirical antibiotic. And then certainly the bacteriologically confirmed true positive cultures, and we give a definitive therapy. So antibiotic use within ICUs is most commonly where we place here, the empirical antibiotic. And in some cases, this can be a syndrome directed, like a patient coming with cough, sputum, expectoration is there, fever is there. So we are suspecting some sort of chest infection and we try to address that. But in most of the critically ill patients, a source of infection is not easily defined. And when we have a patient in our ER or in our ICU coming in sepsis or septic shock, we have to go in for the empirical therapy, thinking about like what can be the source of infection and how we are going to prescribe it. So there are certain steps in selecting the empirical antibiotic. First of all, we ought to know, is there an infection? Again, a very difficult question to answer. Where did the patient acquire the infection? Is it a community acquired or is it a hospital acquired? Then what are the effect modifiers? We'll be talking about all these things one by one. So effect modifiers need, the patient settings and certain other criteria wherein we can have the multi-drug resistant organisms, and we need to look on those factors. Then what are the comorbid conditions, the patient conditions, and the severity of illness? This is one of the prime decider in our subset of patients. So first and foremost, when we start thinking that we need to give antibiotic, do I actually need to give antibiotic or not? So this is the most difficult question because to start with or not to start with, we have to answer before we give any antibiotic. So the answer is certainly yes, if any of these questions have a positive response. That the patient has a proven bacterial infection, then it is obviously not a empirical antibiotic, rather we are using the definitive therapy. If a culture is positive, we have to give the antibiotic. If the patient's presentation is consistent with an immediately life-threatening infection, then again, the answer is yes. And if the patient is in septic shock, the patient is in hypotension due to a suspected infection, then again, the answer is yes. But we can always wait and watch if we have a patient who has undifferentiated febrile, patient who is not hypotensive, patient has a catheter in situ, and we consider that it's a colonizer with a low virulence organism. So again, we can just wait. Or if we have some ventilator associated condition where we are almost sure that it might not be an infection, but it can be just a colonization, and we can just wait. So if at all, amongst all these three questions, the answer is yes, then there are certain subsequent things, how to reach the optimal antibiotic therapy. And all these things have to be covered one by one, but mainly I'll be addressing the adequate coverage. But before we start with the adequate coverage, most important thing which I always want to emphasize is the adequate timing. I think we all agree this was a landmark paper published in around 19 years back by Anand et al., Kumar et al., which said that with every 1 hour delay of antibiotic prescription was associated with average around 7.6% of decreased survival. And from herein, the concept of early antibiotic within 1 hour of recognition is wherein this concept has come about. And certainly many studies subsequently showed that with every delay, even from the triage, more than 3 hours delay, this was a meta-analysis of around 8 studies which showed that 1 hour, more than 1 hour from septic shock showed that the survival rates decrease. So we are now very sure that within 1 hour of our recognition of sepsis or septic shock, we should be prescribing our antibiotic, but certainly after having appropriate cultures. Now, the main question is the adequate coverage. What and how to prescribe? What is not a simple answer. It has to be a stepwise approach. First of all, we ought to know the likely source or the probable site of infection. Although not an easy sort of concept, because sometimes the source might be evitable, but most of the times we cannot look at what is the primary source. So primary source can be a lungs. Again, we have to look in for that whether it is a community acquired, where we have acquired the patient has acquired the infection. Is it a community acquired or a hospital acquired? Is it a urinary tract? Again, bloodstream infection. Is the patient being shifted from somewhere else with any central line in situ, or is it a patient is a on dialysis patient having a dialysis catheter in situ? Again, we need to look into all those aspects. Then, is it an abdominal or a GI source, or is it a skin and soft tissue infection? Again, is it a localized abscess, or is the patient presenting in fulminant necrotizing fasciitis? But usually it is a sepsis with unknown source. So when we examine the patient, when we look at the patient, we ought to try to pinpoint that what is the likely source of infection, which if we go into the depth with the history and the examination, there can be some pointers which can specifically point out the likely source of infection. Most importantly, we must always remember the normal flora, and because not all the microbials are bad. So the normal flora of the body must be kept in mind. And this was a beautiful narrative review published in Lancet just 3-4 months back in January 2025, which said that multiple studies have shown that depletion of commensal anaerobic gut microbes by specifically prescribing anti-anaerobic antibiotics influences the systemic immunity and has been associated with increased mortality in patients with sepsis. So the authors do aim to raise an anaerobic awareness, wherein every GI surgeon, everybody is just prescribing the anti-anaerobic antibiotics, but there is potential detrimental effects of anaerobic depletion in sepsis. So we must be very careful while prescribing this also. So the point is that we do not want to just destroy the normal flora of the body. Then subsequently, once we're trying to pinpoint that what is the source of infection, we ought to think about like what might be the likely infection. Is it a bacterial infection we are looking at? And if bacterial, is it a gram positive or a gram negative? Is it a fungal infection? If patient is immunosuppressive, patient has been on immunosuppressive therapy for quite a long, patient has some malignancy, patient is a diabetic. So are there certain factors which are associated with fungal infections? Or we are simply dealing with viral infections with no antibiotics needed at all. Like there's a seasonal variation, like in North India, many times during August, September, we have lots of influenza. So we need to look onto all these factors also before we start with any antibiotic. Then when we talk about the specific type of infection, we ought to know the gram positive and the gram negative bacteria. We must go back and revise our microbiology, which we learned in our medical schools, that what are the gram positive bacteria and what are the gram negative bacteria. This is more important because once we have the stains available, like we sent a sputum for gram staining, and they just have the report back that you have gram positive cocci, gram negative bacteria. So we must all be familiar with what are the gram positive bacteria, what are the gram negative bacteria, and what are the atypical ones. So please go back and revise the basic microbiology, which we must all be aware, because most of the infections are due to gram positive bacteria or the gram negative bacilli, gram-positive cocci and the gram-negative bacilli. Mostly, these are the two types of organisms. And sometimes the gram stain report says that it is a GNCB. So gram-negative Coccobacilli, most commonly, it can be an Acinetobacter. So if we know the basic microbiology, we can be more appropriate with our empirical therapies. This is one thing we must all be very much aware of. What is the spectrum of the antibiotics we are prescribing? If the gram stain says that we have a gram-positive cocci, and what we are prescribing is simple astronam, it won't work there. The spectrum of each and every antibiotic we must be aware of. This is there is no excuse for this, and we must all be very much aware of what are the anti-pseudomonal antibiotics, what are the typical anaerobes. Typical anaerobe includes the metronidazole, but linezolid and clindamycin do have some anaerobic cover. So we must all be very clear, like what are the purely gram-positive antibiotics available, what are the pure gram-negative antibiotics, and which are the antibiotics which have a spectrum, broad spectrum. So like if we talk about the cephalosporins itself, starting from first generation to fourth generation, the spectrum changes. So we from simple gram-positive to the fourth generation cephalosporins have a very broad spectrum, except for MRSA, they cover all the gram-positive, gram-negative, bacilli, gram-negative, cocci, everything. And the carbapenems usually have an anaerobic cover too, beyond the gram-positive and the gram-negative covers. So this basic understanding of the spectrum of the antibiotics we must have before we go in for the prescription of the antibiotics. Another important concept, does the antibiotic actually reach the site of infection? We all must be aware of this, because many a times we are prescribing some antibiotic and we ought to forget that does this actually will reach the suspected site of infection. Like if we talk about the meningitis, we have to think about only those antibiotics which do cross the blood-brain barrier. So like if we talk about the lungs, if we have a gram-positive infection, daptomycin is not the drug of choice, because daptomycin is usually inactivated by the surfactants in the lungs. So all these things we need to keep in mind. Like if we are talking about the bloodstream, the urinary tract infection, tigecycline is not the drug which will reach the appropriate concentrations in the urine. And even in for a bloodstream infection, tigecycline doesn't attain the appropriate plasma concentration. So all the antibiotics must we have to select as per the penetration. We must know that which are the appropriate antibiotics which will penetrate the specific site of infection. Like if we have a necrotizing pancreatitis and we want to, that is an infected one, and we want to prescribe antibiotics. So we must be very much aware of which all antibiotics penetrate the pancreas. And when we talk about some abscess, we must be aware of that the pH in the abscess, it is too acidic and actually does not it actually inactivates almost all the antibiotics we prescribe. So the source control therein plays an important role. And most of the antibiotics have a very poor penetration into the abscesses. So when we are prescribing the antibiotics have to be prescribed as per the site, which the previous slide I have mentioned, that the penetration we have to keep in mind, and what is the optimal concentration. Is the antibiotic reaching optimal concentration at that particular site? We must be rational about it. And I always tell my residents that whenever in doubt, we go back to the Sanford guide. This is, I think, the Bible of antibiotics in ICUs, and we always tend to consider this whenever we are in doubt. We don't know, there's some very different organism reported. So anyhow, this guide is a must for almost all the ICUs, I'll say. It tells you about the first line antibiotics, the choice of second line antibiotics, as per the site, as per the type of infection, as per the specific microorganisms also. So this you can just always go back and consider this if you don't know actually how to go about the antibiotic prescription. The other thing we have in mind is going in for combination or a mono antibiotic therapy. The combination certainly has theoretical advantages. We are giving a broader coverage. More synergistic effects might be there when we prescribe two antibiotics from two different classes. And there is supposedly a decreased risk of development of resistance, but mostly because of the increased exposure to antibiotics, actually it can itself drive the resistance. And certainly there are risks of toxicity and increased costs is a factor. So many studies have shown no difference in survival when we use a mono versus a combination therapy in septic shock patients. And most of the studies, they conclude that as long as the causative pathogen is covered with a single empirical therapy, additional agents will not give any additional benefits. Even this meta-analysis of around 10 studies, it again showed there's a favorable response with mono antibiotics. And the consensus as of now is that combination therapy with double coverage should be reserved for patients who are severely ill with septic shock and likely to be having at risk of multi-drug resistant gram-negative infections. And when we talk about the antibiotics, the prescription of antibiotics, we must also know the correct dosage and correct administration. It's more important because when we talk about sepsis, that is what this talk is specifically about. We must understand the physiological alterations which are occurring with the PKPD of the antibiotics. So sepsis, we know there's an increased cardiac output, hyperdynamic circulation is there, thereby they can be having elevated clearance. And even with volume resuscitation, the fluid administration, lots of fluids we're giving, that increases the volume of distribution. There are leaky capillaries and altered protein binding, which will all increase the volume of distribution, leading on to the lower plasma concentrations of the drugs. So we might need to give actually higher drug dosing as compared to what we routinely use. But this organ dysfunction, like patient might be having some renal dysfunction, the hepatic dysfunction, these all will lead on to decreased clearance and thereby increasing the plasma concentrations. So we ought to maintain a balance between the dosing of the antibiotics. But always remember that the loading dose is to attain the effective concentration in a minimum time. So loading dose is not affected by renal function and should always be a mandate in all our ICU population wherein we start prescribing an antibiotic. So please do not miss out the loading dose of the antibiotic because patient is into renal failure or patient is into just shut down. So we are not giving the loading dose, but that is not rational. Then we must understand what are the time-dependent antibiotics and the concentration-dependent antibiotics and how we are going to give those specific antibiotics. And the time-dependent antibiotics, we all know the beta-lactams, the glycopeptides, macrolides, they're all the time-dependent antibiotics, wherein the time for which they remain in the plasma concentration is above the MIC. That is the major role player. And therein we want to give the antibiotics in an infusion, and the concentration dependent antibiotics must be given as a single loading dose. The aminoglycosides and the fluoroquinolones are the most important antibiotics in this class, and herein the concentration achieved above the minimum inhibitory concentration is what matters. But these antibiotics usually have a good post-antibiotic effect. So prolonged post-antibiotic effect also plays a role in their actions. So this is just, I wanted to highlight that we ought to know how to give these antibiotics. Like aminoglycosides usually have to be given as a single dose rather than giving as a twice a daily dose of amikacin. That is not what is scientific. So empirical therapy, the dilemmas are that we need to give an adequate therapy with adequate coverage against most likely pathogens, and at the same time minimizing excessive antibiotic use and thereby decreasing the spread of antimicrobial resistance. So initial antibiotic selection must account for the host factors, the microbiologic factors, and the pharmacologic factors, which we have just discussed. It should be a broad spectrum. So we ought to know the spectrum of each antibiotic. The agents combination have to be from different classes. We cannot just combine meropenem with cefepime. So we have to have agents from different classes. Different classes means different classes having different spectrums, like one from gram-positive. We can combine meropenem with teicoplanin, but we cannot combine meropenem with ampicillin. And rather, they should be based on the institution-specific data with local antibiograms. I hope all of you understand the local antibiograms. Antibiograms are, they tell you about the individual site of infection, what were the most common microorganisms which were causing those infections. Like if we talk about UTI, what are the 5 most common organisms and what was the sensitivity, the most sensitive antibiotic for that particular infection, that particular bacteria. So we must know, because what is the sensitivity in our particular ICU? That is what matters when we decide the empirical antibiotic. So I think most of the hospitals do go in for their local antibiograms, which is made on the previous year's susceptibility patterns. And if at all not there as of yet, you can always, emphasize on your microbiologist the building up of these local antibiograms, which will be very helpful when we start prescribing the antibiotics. So factors for selecting empiric antibiotic, they are the patient-specific factors. What are the comorbidities? The presumed source of infection, which we have already discussed, the blood, sputum, urine, or it is the meningeal infections. The comorbid conditions, did the patient have any chronic illness? Is there a recent surgery, trauma, previous antibiotic administrations, microbiologic factors, the identification of most likely pathogens and the unit-specific susceptibility patterns, the pharmacologic factors, the drugs, what is the penetration, what is the likely spectrum of that particular drug, and the potential drug toxicity, bioavailability, and distribution to the site of infection. So all these factors we have to think about when we prescribe an antibiotic empirically. And we must always remember the risk factors for MDR pathogens when we talk about the hospital-acquired infections, or even if it's a community-acquired, but the patient had recent hospitalization, patient had prior antibiotic use within the last 90 days, or the patient is a resident in a healthcare associated facility, like he is living in a nursing home, he's a healthcare personnel, or patient is on maintenance hemodialysis, and even the symptoms after 5 days of hospitalization and or mechanical ventilation, again, therein the patient is likely to be susceptible for multi-drug resistant pathogens. And patients who are immunosuppressed, they are again at risk for MDR pathogens, wherein the selection of empirical antibiotic will be different rather than for the community-acquired infections. So Indian Society of Critical Care Medicine has given beautiful guidelines for antibiotic prescription in intensive care unit. This was published in IJCCM in 2019, and subsequently they have given for each subset of infections what should be the empirical antibiotic choice. We will not say that it is the ideal, but it can just give you a guidance, like what are the common pathogens we must have in mind, and then how empirically we can just start with the empirical antibiotic. So if we talk about the community-acquired infections, we know mostly community-acquired pneumonias are most commonly gram-positive, caused by Streptococcus pneumoniae, Streptopyogenes, or there can be the gram-negative bacilli. Then the atypical organisms are more commonly associated with community-acquired infections, where it can be a viral infection wherein we do not use the antibiotics at all. And there can be the less common causes in certain subset of patients with wherein we can have the staph, the Legionella, or Mycobacterium tuberculosis. Or in patients with structural lung disease, the most common pathogen can be simply Pseudomonas. So when we talk about the empirical therapy, non-pseudomonal antibiotics, wherein there is no risk factor, we think that patient only has community-acquired pneumonia, patient is coming with symptomatology of chest infection, so we can just start with ceftriaxone, ampicillin with a macrolide, because atypical organisms must be covered when we have a community-acquired infection. Then we can just give empirical vancomycin or teicoplanin added to the regime if there is the MRSA is a consideration, the specific institution, the specific population, the community has some MRSA infections common. So we can empirically add, but usually routinely in our ICU subsets, we do not, when we receive patients in our hospitals, we do not give empirical vanco or teico. And if Pseudomonas is likely, then we need to give anti-Pseudomonal antibiotics, including ceftazidime or ceftriaxone, pipratezo or carbapenems we can prescribe. So if it's a healthcare-associated pneumonia, then we need to look at, is it a early onset or a late onset? Early onset healthcare-associated pneumonia means within first 5 days of hospitalization, and there is no recent antibiotic exposure in the last 90 days. So again, the causative organisms are almost the same as of community-acquired, and again, the treatment is also the same. But if it is a late onset healthcare-associated pneumonia, late HAP means after 5 days of hospitalization. So therein the more MDRs, they come into picture, and patient can have MRSA if the hospital has high incidence of MRSs. It can be a more of a gram-negative pneumonias, Enterobacter, Proteus, or Pseudomonas. And therein the initial therapy, empirical therapy, should be cefepime, ceftazidime, or meropenem, the broad spectrum antibiotics, the carbapenems, or the fourth generation cephalosporin or a BLBLI combination. Plus, we can combine with an aminoglycoside and vancomycin or linezolid if there are high MRSA infections in the ICUs. So if the patient has ventilator-associated pneumonias, then most commonly, again, aerobic gram-negative bacilli are the most common organisms which cause VAP. And most commonly in these days in Indian ICUs, it's the Klebsiella, which is the culprit. It can be Acinetto or a Pseudomonas, and can be a Staph aureus too, and can be a MRSA. But specific MDR pathogens causing HAP and VAP, we must understand that they vary by hospital types, the patient population, the type of ICU patient, and they keep on changing over time. 5 years back the line, our ICUs had more common of Acinetto. In the last 1 or 2 years, Klebsiella is the main culprit. And even beyond, I think 7-8 years back, Pseudomonas was pretty common in almost all the ICUs as a VAP-causing organism. So they keep on changing, and this is where we need to look into the antibiograms of our specific ICUs. So VAP treatment certainly needs a broad spectrum antibiotic. Single antibiotic, including any of the third or fourth generation cephalosporin or the carbapenems, or a BLBLI combination. And if VAP is due to MRSA, high suspicion is there, we can start with glycopeptides or linezolid. And if the ICU has a high prevalence of CRE, then colistin can be started empirically. But empirical antibiotic regime for VAP should not include coverage of atypical organisms. Mind you, you're not going to give clindamycin or the clarithromycin or azithromycin for VAP treatments in combination with the carbapenems. So if we talk about meningitis, again, we know most commonly gram-positive cocci or the gram-negative cocci are the most common organisms, but it can other species, including the Staph, Pseudomonas, can also be the positives, mainly for the post-EVD or catheter meningitis, wherein we say the hospital-acquired or the meningitis. So again, the treatment for meningitis, empirical treatment for community-acquired meningitis is the third generation cephalosporin, which have a very good penetration into the blood-brain barrier, along with vancomycin as empirical antibiotics. And for patients who are more than 50 years, we ought to combine with ampicillin or amoxicillin. But if it's a nosocomial or the hospital-acquired meningitis, then vancomycin plus we need to give a higher class of antibiotic, including cefepime or ceftazidime or meropenem, wherein it can cover the more MDR organisms. Again, if carbapenem resistance is common, then colistin should be started. And if it is a brain abscess, then we need to add on the anaerobic metronidazole as empirical antibiotic of choice. This is what the guidelines, ICU guidelines say, and most of the things they are covered in these guidelines, that this is how we empirically should start our antibiotics. For catheter-associated UTIs, again, gram-negative bacteria are the most common culprits, and there can be the fungal, but we must understand that 70% of the candida in urine is mostly a colonizer. But if the patient has acute pyelonephritis, then it can be a gram-positive organism, and we need to cover the, give a gram-positive antibiotic also. So UTI treatment, mostly we have to cover for the ESBL organisms, the aminoglycosides plus a BLBLI or a carbapenem, and no gram-positive cover empirically unless the imaging shows that patient has some acute pyelonephritis or rather emphysematous pyelonephritis is there, because Enterococcus can be one organism which can lead on to this UTI. So if we talk about peritonitis, again, third generation cephalosporins are the perfect choice for primary peritonitis. But if it is a secondary peritonitis, then we might need to give a BLBLI or a carbapenem along with metronidazole only for secondary peritonitis, not for a primary. So catheter-related bloodstream infections, most commonly caused by Staph aureus. It can be cons or Enterococcus, Candida, not very frequently, but with underlying diabetic patient, immunosuppressed patient, we can have fungemia there. And especially the non-albicans Candida can be the culprit. But Staph aureus and cons are most common, but methicillin resistance in Indian scenario is less common, 10 to 15% reported, but in Western world, it is very common. So we might need to cover the MRSA empirically here. So CRBSI, again, if the patient has bloodstream infection, empirical antibiotic regime should cover both gram-positive and gram-negative bacilli. And we must remember that the carbapenems, they cover all GPCs except for methicillin-resistant Staph aureus. So if we are suspecting MRSA or MR-cons, then only the vancomycin or teicoplanin can be recommended as first lines. But otherwise, with meropenem, we need not combine the vanco or teico. So empirical coverage for gram-negative bacilli can be the fourth generation cephalosporins, carbapenem, the same spectrum. And suspected candidemia should always be thinking that there can be fungemia. The patient has fungal infection in the blood, echinocandins are the drug of choice. But if the sepsis is from unknown cause, and we are suspecting that it's a community-acquired sepsis, empirical antimicrobial therapy with combination of ceftriaxone along with doxy or macrolide, because here in Indian scenarios, tropical infections are more common, including the lepto, scrub. Especially, I'm not very particular, know about much about the south, down south, but in northern India, being the foothills, there are lots of scrub infections are there. So patient presenting with fever and in shock with some rash, doxycycline should be prescribed in the community-acquired sepsis itself. If it's a nosocomial sepsis, then BLBLI with aminoglycoside or fluoroquinolone can be the choice. But if the patient is in septic shock, it is always preferential to start with a BLBLI, carbapenem, and along with a MRSA cover. And if fungal infection is suspected, then echinocandin. So common errors we routinely have in antibiotic use is delay in antibiotic administration. Always remember the 1 hour window. So antibiotics should never be given before the cultures. So remember to send the antibiotics, remember to send the cultures, appropriate cultures from suspected sites of infections, and then only prescribe the antibiotics. And usually, there can be a poor choice of empirical antibiotics if we do not take into account all these factors we have discussed and even the resident flora of that particular site. And failure to consider the tissue penetration of different antibiotics, inadequate doses, excessively long courses of antibiotics, a 7 days, 5 to 7 days of antibiotic course is as good as a 14 days course, and erratic changes of antibiotics in non-resolving sepsis, inappropriate use of antibiotic polypharmacy, which must be avoided at all costs, and failure to de-escalate to monotherapy, especially when we have the definitive cultures available. So principles of appropriate use of antibiotics, including taking two culture sets before administering antibiotics, do not delay administration, use broad spectrum empirically and narrow later, use local antibiogram for the empirical therapies, ensure sufficient dosages, just avoid underdosing, and de-escalate to definitive treatment once the culture report is available. And most importantly is know when to stop. So if we have the definitive cultures, there is no gram-positive, the culture is growing only E. coli, we ought to stop the teicoplanin. We have started as an empirical therapy. So know when to stop also. So if microbiology results suggest certain susceptibility, consider whether it is working, the specific antibiotic is working clinically or not. And if bedside evidence says that it is working, the patient is clinically improving, despite we don't have the sensitivity pattern, you get a culture report after 3 days. After 72 hours, you are receiving the culture. But by that time, the patient TLC has come down, patient is not toxic, patient has no fever spikes, patient, the blood pressure is stable now. So we can just continue with the same antibiotic therapy because in vitro sensitivity does not always predict the in vivo effects. And always remember, a shorter course is probably as good as a standard 2-week course. Only the prolonged antibiotics should be prescribed for wherein we have the MDR pathogens. And wherein you have the availability of ID specialists, please do involve them into the prescription of the antibiotics. And we always suggest that the microbiologist should also be a part of the clinical antibiotic prescription team. So monitor antibiotic levels, if at all you have the available, the therapeutic and these monitorings, and adhere to the infection control policies, and always have an antimicrobial stewardship program in the ICU with restricted antibiotics to be actually restricted. So to conclude, there's no such thing as a strong antibiotic, and our favorite antibiotic must not always be the best. So use antibiotics judiciously, and always remember the 8 rights of medication administration. This applies as good as to the antibiotics also, that we have to prescribe the right antibiotic to the right patient at right time in a right dose for the right reason, giving through a right route and right response and right documentation. So actually antibiotics are not toxic. I think we are. And thank you for being not resistant to this presentation. Thank you so much. So if at all you have any questions, you can drop in or.
Thank you, Kawal, for a very, very exhaustive and covering almost all the aspects one needs to look at while prescribing an antibiotic, especially in situations where you are not sure about what the organism is. I completely agree with you. There is a general tendency to prescribe the most broad spectrum or the most costliest antibiotic, thinking that they might work. But then again, until unless you're very, very sure about what the organism is, many a time, if you know what could be the potential source, then maybe a simple antibiotic would be sufficient. For example, if you're suspecting a meningitis, a simple ceftriaxone is what we need. Similarly, in many of the tropical infections, adding a simple doxycycline can do wonders. So it's not necessarily always the carbapenems or the cephalosporin which work, but it also is important to know what could be the potential source and the likely organism. And whenever we say empirical, we are looking at covering those organisms which are responsible for causing that particular infection. Thank you so much. I think Dr. Srinivas is there. Yeah, Srinivas is there. Srinivas, your thoughts?
Yeah, I think it was a very comprehensive and crisp description of what we need to do to factor and control antimicrobial resistance and some. It is a discipline which we all need to learn, and Kamal has actually showed us the reality check of what we are doing or what we may not be doing. Critical care ICU prescription is a different ballgame. Sometimes the problem with the ID specialists is they may not be actually aware of the impact of extracorporeal circuits and techniques in drug clearance. So we should be able to give them that perspective, and in synergy, we should be able to make antibiotic prescriptions safer and more effective for patients. And drug dosing in AKI, drug dosing on RRT, drug dosing in ECMO is a different topic by itself. Maybe in some other session in Hicks, we will discuss
I
that as well.
think we were planning to do that next week. Kamal, I think
Yes, I'll work on it. We were also thinking, because me and Dr. Kancham were discussing, that we need to have the drug dosing and extracorporeal therapy. So we'll be
Yeah.
covering in the next Tuesday.
Yeah, thank you for volunteering, Kamal. Nobody better than you to do it. So, okay, thank you all. Please do join us. We know what you're going to hear next week. So please do join us again next week on the Hicks platform. Subscribe to the YouTube channel, and please do register for the annual 10th edition of Hicks on June 19 to 22. See you all very soon. Goodbye and have a good day. Bye bye.
Thank you, sir.
thank you. Thank you.
Thank you, Kancham.